central phase of gastric secretions, the influences are mostly inhibitory, and these inhibitory influences are on both secretion and peristalsis of the stomach. Inhibitory secretory endocrine influences come from the hormones collectively known as enterogestrone, which includes CCK, which includes secretin, and which includes GIP, glucose-dependent insulinotropic peptide. Also, there is the inhibition of motility through the sympathetic influence, sympathetic inhibition through the long reflexes, and also long reflexes. So after pancreatic surgery, obviously there is not enough of enzymes, and the chyme probably is like it says here, hyperosmolar. Apart from this, it may have high level of fats, and also glucose, also high level of carbohydrates, and normally this should already close the pyloric sphincter, right, and stop the emptying. So in this case, it's normally CCK mediated inhibition of gastric emptying that is absent in this case, probably due to the high osmolarity of the chyme, high level of fats. So gastrin-mediated stimulation of antral contractions would promote gastric emptying. It's already very high, so that's why A is wrong. Secretin-mediated relaxation of the pylorus. Secretin does not relax the pylorus. It closes the sphincter, the pyloric sphincter. Receptive relaxation is related to cardia, not esophagus. Okay, so receptive relaxation is relaxation of cardia together with the opening of lower esophageal sphincter. Triglycerides are not part of it. You know that glucose goes by sodium-dependent transport as GLUT1 across the apical membrane, and amino acids also sodium-dependent transport. Triglycerides are not. They are first of all broken to monoglycerides, and then they come as micelles, so they do not require sodium, and they can freely cross, monoglycerides can freely cross the membrane, so they don't require sodium. So all of them are present, and stimulation of all of them causes increased secretion of hydrogen, hydrochloric acid. Okay, yeah, no. What was 5? No, cholinergic are there, M3 receptors are there. And CCKB also affected by gastrin. CCKB are affected by gastrin. They are on parietal cells. Sodium dependent, again amino acids, not fatty acids or triglycerides. They do not require sodium. They require bile salts for micelles, and then inside the enterocytes, chylomicrons are formed. Some short fatty acids can go directly from the enterocytes into the blood and lymph. take pictures, I don't mind, whatever. But I will post this as soon as I complete reviews with everyone. I will add these questions to the corresponding sections. Okay? So I might be adding more, so keep doing the questions.
I have a question about this one. I actually don't understand why the saliva would be viscous.
That is inhibition of parasympathetic nervous system, which normally produces a lot of watery saliva. So once inhibited, remember the case we had belladonna poisoning? She had dry mouth. And on the whole, the cholinergic crisis, which is severe inhibition of cholinergic receptors by anticholinergic drugs or by anticholinergic drugs mostly, that is dry as a bone, red as a red as a bit, and what else? So the patient is flushed. All the vessels are dilated because that is the only form of heat release, because all the gland secretion is inhibited. So patient is dry as a bone. No saliva, no gastric juice, no pancreatic secretion, no nothing. Lacrimal glands are not secreting. Sweat glands are not secreting. So that is why release of heat is only through the dilated vessels. So that's why the face appears as red as a bit, dry as a bone. Blind as a bat, because the pupils are dilated. So in the bright light, normally we have pupil constriction. Pupils are very much dilated, patients can't see properly. So blind as a bat, mad as a hatter, because there are M receptors, there are 1 and 4 and 5 in the brain. Interrupted due to the interruption of cholinergic supply to the glands. Has nothing to do with somatostatin. Somatostatin release is stimulated mostly by what? Low secretions, low acidity of the stomach. High pH. Low acidity, high pH. Low acidity means neutral pH or high pH.
No, but wouldn't the pH be low, like 1 or 2 if it was really acidic?
Low acidity. Yes, pH, low pH is high acidity, right? Because pH is measured as a logarithm of concentration of hydrogen ions.
Yeah.
So the more is hydrogen ions, the lower is pH. And vice versa.
Decrease somatostatin though, because it inhibits like the gastric release. Wouldn't you want to make more gastric then? I'm so confused.
Okay, let's look at this. So what happens here?
I got this question right.
Acid secretion is decreased. Acid secretion is decreased, but as the result of the surgery. Okay, not because of anything else. So you have to relay the question to what happened to the patient. And it says that the surgeon, young surgeon, clumsily cuts the patient's vagus. So vagus cut means no acetylcholine release, right, on parietal cells. Because parietal cells have direct, they have M3 receptors, so they get supplied with vagus. If vagus is cut, the consequence is no acetylcholine released of the. So it has a cut of vagus has nothing to do with somatostatin. Somatostatin increases when there is high secretion of acid.
Yeah, that's what I was saying.
But it's not the case here, because he was not helped with antacids or anything else. So it obviously would not. The mechanism did not work for him because he already had too much acid. So obviously the natural mechanisms of inhibition did not work for him. That's why he was taking antacids, and even antacids did not help him. So he was only helped by the cut of vagus. so high level of gastrin. And remember, there's gastrin-histamine mechanism, and enterochromaffin-like cells secrete histamine, so gastrin stimulates histamine and hyaluronic acid.
This one was mentioned in the slides, I think.
Yeah, of course.
This was recalled.
So G cells is wrong. G cells are not stimulated by gastrin release. Okay, they release gastrin, but not stimulated. Okay, perfect.
Yeah, this one was confusing.
Is confusing?
Yeah.
Why?
I don't think I had time to actually properly answer the question, but I was confused about it as well.
So what is happening? He has oral solution of electrolytes, Pedialytes. I think we had this case even in foundations. Remember when we were talking about sodium being added in order to add the absorption of monosaccharides. So clever mother who doesn't have readily available Pedialyte gives some boiled water with sugar, table sugar and table salt. All right. So this will only work provided patient has enzyme to break the sugar, because she gives not glucose, she gives saccharose, sorry, she gives saccharose, for which enzyme saccharase is required. Otherwise, the glucose would not be absorbed. So she gives the sugar that we have is not is a complex sugar. It's saccharose.
My
That we have.
confusion was
This
that I
table
thought
sugar.
she was giving her glucose
No.
directly. Because I read sugar and I was like, oh yeah, she's giving her glucose. But then I was confused because sucrase was the only sugar enzyme.
Because as I told you, and it's on the slides, we consume starches and disaccharides mainly. Lactose from milk, it's a disaccharide. Sucrose, the sugar that we have on the table, either in cubes or in powder, whatever, right? This is sucrose.
Oh, okay.
We don't consume monosaccharides. They are the result of breakdown by these brush border enzymes. Gastric emptying. So it's vice versa. Gastric emptying is inhibited by high acidity in the duodenum. Of course, if pyloric tone is increased, this closes the sphincter and this cannot increase the emptying. A reduced number of spike potentials in the stomach would mean that peristalsis is decreased, right? Spike potentials are what? Action potentials on top of those slow waves. So the action potentials are prerequisite for contractions. So if the number of spike potentials decreases, means contraction are decreasing. So this would decrease, not increase gastric emptying. High osmotic pressure in the duodenum would close the pyloric sphincter and again decrease, not increase. It's only when pH is high, which means slightly alkaline or neutral, then emptying would continue or would be facilitated, because inhibition would be absent. Okay. So this is what the pain is caused by contraction of. The pain is always in the body. The pain is always spastic. Spastic contractions. So that's contraction of gallbladder caused by CCK. CCK comes from I cells. G cells gastrin has nothing to do with gallbladder. D cells are only releasing somatostatin, which inhibits everything in terms of secretions, both exa and endocrine. We will learn it in next block. That somatostatin also inhibits glucagon and insulin, and cell secretes secretin. Also, it has to do mainly with secretions, not contractions. I thought we already discussed it. So which of the following best describes the mechanism of action of omeprazole? It says here proton pump inhibitor. Proton pump is primary active transporter, potassium hydrogen exchange. It's primary active. If you don't remember it, go back to foundations. But I mean, you may not remember that it's primary or secondary, whatever kind of transport, but you can exclude everything else, right? Trypsin, right? High level of trypsin, trypsin activation in the gland, trypsin activation in the duct. What substance normally prevents premature trypsin activation in the ducts of the gland? PSTI, right? PSTI, pancreatic secretion trypsin inhibitor.
I thought trypsin was activated at really low pH though. That's why it's activated in the stomach and not in the pancreatic ducts. Or was it another?
No, wait. Trypsin normally is activated in the why in the stomach? Trypsin is enzyme coming from the pancreas.
Yeah.
It's normally activated in the duodenum.
Oh, right.
Of
Duodenum,
course,
sorry.
in the duodenum, not in the ducts of the pancreas. In the ducts of the pancreas is only in case of pancreatitis, and we also had this case of alcoholism, right? Pancreatitis due to alcoholism, which is most common cause of pancreatitis in male after the age of 40-45. So if they're chronic alcoholics, the pain is caused by autodigestion of the pancreas. So that's trypsin premature activation. So ulcers of the stomach and duodenum. Ulcers in the duodenum are the result of hypersecretion of hydrochloric acid. Ulcers in the stomach are the result of lost protection. So on top of increased secretion and lost protection, patient has both stomach and duodenum ulcers. So that's about high level of hydrochloric acid secretion. So secretion hydrochloric acid is parietal cells, not G cells, okay? So we want to inhibit hydrochloric acid secretion. We want to give proton pump inhibitors. So inhibition of again cholinergic receptors. This would be low levels of saliva, viscous saliva, dry mouth, inhibition of contractions, because contractions throughout gastrointestinal tract are cholinergic. They are activated by acetylcholine. All the receptors are M3. Even where we have the skeletal muscles, though these receptors would not be inhibited by because they're not muscarinic, but it's still acetylcholine. It would be decreased secretion everywhere, dry as a bone, decreased peristalsis, so B and D are about the same, so you automatically can rule them out. If you see the two disruptors are speaking about the same, because you understand the spike potentials or actions potentials are directly related to peristalsis. There can be no contractions in the body without action potentials. So you cannot have two correct answers. So you can rule them out immediately. Internet is very slow. So receptive relaxation is cardia, not esophagus, okay? It's the function of the stomach, because stomach serves as the container for the food, as the reservoir for the food. It keeps the food, so it has to relax automatically as soon as lower esophageal sphincter opens.
Why would this upper esophageal sphincter work here? Isn't it also relaxing when you're swallowing?
But it's not receptive relaxation. The term receptive relaxation applies to stomach.
Oh, okay.
It's on the slides. The only nerve right now I want you to memorize is vagus, right? All of them, 5th, 7th for sensory portion, 10th, 9th, and 12th are involved in swallowing. You have to remember vagus. The rest you will learn later. Endoplasmic reticulum is where re-esterification is taking place. So the components of micelles, once they enter the enterocytes, they are restored back to triglycerides, back to cholesterol ester, back to phospholipids in the smooth endoplasmic reticulum. In the colon, again it's on the slides. Enteropeptidase, of course. So the appropriate activation of trypsin. So that's about activation of trypsin. Amylase is an enzyme that breaks starches. Enteropeptidase, or another name for it, enterokinase. So but the more accurate is enteropeptidase because this is what it does. What else? Yes, what's the function? Sphincter relaxation, and what else? Vasodilation and secretion. Secretion. Okay, the secretory diarrhea. Mucosal integrity. And the process which is because the brush border is destroyed by the antigen-antibody reactions and inflammation. So that is, remember the microvilli, how they look like. So the villi are destroyed, and this affects which process? Digestion, absorption, or absorption, right? Absorption. Yes, celiac disease. Cholera toxin. You had it with Dr. Ahmed. Pacemakers, interstitial cells of Kajal. Alright, I am done for today. That's the last one. I will post, after I'm done with everyone, basically on Thursday, I will be posting them, just adding them to the existing topics. So keep doing questions, alright? Keep doing questions.